Another common cause of diarrhea is apparently irritable bowel syndrome. And I just threw out 25% of healthcare providers have IBS. Somebody did a big old study, and that was the results of the big old study. So let's talk about IBS. IBS is pretty darn common. You will know if you have IBS on the morning of your certification exam. Okay, if you're laughing, you got it, because you know what I'm about to say. So here it comes. Your exam is set for 10 a.m. You ready? Your exam is set for 10 a.m. You set your alarm for 6 a.m. 6 o'clock, your alarm goes off. You wake up. Man, today's the day. Going on in the lower abdomen. You get out of bed, you're doing your thing, maybe making some coffee, trying to get in the shower, 6:20, BM. 10 minutes later, BM. 10 minutes later, another BM. BM, your gut is emptied. You go in and you take your exam at 10 o'clock. 1:45, you're getting out. Oh, thank God I passed. I'm exhausted, I'm hungry, and I need an adult beverage. And you do it. Next morning you wake up, no BM. 2 mornings after your exam, still no BM. 3rd morning after your exam, still no BM. But your telephone rings. The job you've been dying to get wants you to come in this afternoon for an interview. Boom! You're back in the diarrhea phase. And that is classic IBS. Look, it's an alternation between diarrhea and constipation depending on what's going on with the patient. Very often there's a patient who'll tell you there's a lot of mucus in the stool. And anyway, their complaints are pretty easy to pick up. What do we know about IBS? It's benign. It might make your life miserable, but it doesn't increase your risk of colorectal cancer. It doesn't do any of that. What do you look for always? When a patient comes in and gives you that history, you always have to ask about red flags with diarrhea. So look, we don't know if there's blood. Is there blood when you wipe? Is there blood in the toilet? Is there blood? Because blood belongs in blood vessels. Blood does not belong in the toilet. It does not belong on toilet tissue. So it belongs in blood vessels. Is there rectal bleeding? I want to know about abdominal pain. I want to know if you've lost weight or have abnormal labs, because those are all red flags. None of those are symptoms of irritable bowel syndrome. They might be symptoms of inflammatory bowel disease. And the 2 most common examples of inflammatory bowel disease are Crohn's and ulcerative colitis. When do we see these? We see these typically in a bimodal distribution. Bimodal means we see a little blip on the map somewhere around adolescence up to about 40 years of age, especially with ulcerative colitis. And then the other blip on the map is after age 50. So that's when we see the most common presentation of inflammatory bowel disease. These are people who have abdominal pain. Typically it gets worse. But here's what I want you to realize. They may have had symptoms for years, or months is more like it, before somebody actually diagnoses them. All right? So it's not until they have a big sentinel event, like bleeding, but they've had symptoms all along that really, if not, you just can't put your finger on it. So have a heads up. The last point I want to make about Crohn's and ulcerative colitis is this. It doesn't just involve the gut. It can involve skin in the form of rashes. It can involve the eyes. It can involve joints. We call those extraintestinal manifestations. Sometimes they precede a flare in the gut. Sometimes they occur at the same time as a flare in the gut, or sometimes they occur afterwards. But you need to look for those as clues that may indicate that this is what your patient has, because all of them need referral. All right? Take a look at this question. A stool specimen is positive for leukocytes. Those are white cells. This may be associated with what? And it's to select all that apply. What might make you find leukocytes in a stool? And we often get one because maybe they're having diarrhea. When might you find that? Not in the presence of bleeding, so don't circle that one. Infection, for sure, we see white cells. So maybe a salmonella infection, you'll find white cells. Inflammation, as in the case of what? Crohn's or ulcerative colitis, we find white cells in the stool, so circle number 3. Salmonella infection, yes, infection. Number 5, irritable bowel syndrome. No, right? No, we don't find white cells, but we do with 6 and 7, Crohn's and ulcerative colitis. So take a look. A stool specimen positive for white cells, we see it in the presence of infection, number 2, inflammation, number 3, salmonella, number 4, and number 6 and 7, Crohn's and ulcerative colitis. You got it? So that's the significance of finding white cells in the stool. That might be why you order it, because you suspect one of those is going on. There's an acronym that you need to be alert to, and I suspect you already know it. The acronym is BRBPR. It's bright red blood per rectum. So here's the deal. If you are 40 or older, or if a patient is 40 or older and they come in to see you and they report any type of blood, you're going to send them to have a scope. If they're less than age 40 and they report, I wiped this morning, there's blood in the stool, there were drops of blood in the toilet water, they almost always are going to be scoped, unless when you ask the questions that assess for colorectal cancer, they're 0. So look, if somebody's less than 40 years of age, and you ask them the colorectal cancer screening questions, and they say no on all of them, and you know why they're bleeding, I see hemorrhoids, oh, there's an anal fissure, and you treat it and it goes away, they're not always scoped. But everybody else is. And here's why. The risk of colorectal cancer in the United States is sky high. In fact, depending on your gender, it's either the second or third most common cause of death. Look, the most common cause of death overall in the United States is colorectal cancer. Do you get it? That's why we are so aggressive in managing or are so aggressive in identifying people who have blood in the stool, because it's a huge risk factor. So here's how it goes. People grow polyps in their gut. And most of the polyps that grow in people's guts are adenomatous polyps. You know what that means? It means it starts out as a little benign little old thing, and then it becomes dysplastic, and then it becomes malignant. You know how long it takes to be a plain old polyp to get to a malignancy? About 10 years in most people, which is how we arrived at the screening interval of a colonoscopy every 10 years. You got it? So that's why we do that. Colorectal cancer is extremely common, and that's why screening is so very, very important. What are the 3 questions you always ask? And I hope you ask this regularly with your patients. Right now, I'm going to be the healthcare provider, and you're going to be my patient. You ready? Here's the first question I'm going to ask you. Has anybody ever diagnosed you with colorectal cancer or an adenomatous polyp? Oh, no, nobody ever told me I had that. Good. I'm going to ask you the second question. Has anybody ever diagnosed you with Crohn's or ulcerative colitis? Because those increase your risk of colorectal cancer. Oh, no, nobody ever told me I had that. Good. Now I'm going to ask you the third question. But the third question is not about you. The third question is about your family. And this is the one that casts a big old net. I want to know if anybody in your family has had colorectal cancer or an adenomatous polyp. Because if you answer yes to one or more of those, you're not of average risk. And if you're not of average risk, you know what we say you are? High risk. And high risk, we really want to get screened, and we would prefer a colonoscopy. There are a number of ways that we screen people for colorectal cancer. And before you think, why do we have so many ways to screen people? It's because in the United States, we have very low rates of colorectal cancer screening. So here's how it goes. People come into my clinic when they hit age 50, I'll ask them, listen, I'm looking at your health maintenance record, and for your age, the recommendation is a colonoscopy. Some people will look at me and say, well, what's that? Well, it's screening for colorectal cancer because it's a very common kind of cancer. How'd they do that? Okay, I try to put on my best face. And I tell them, I explain it to them as gently as I possibly can. They look at me after I explain it to them and they'll say, ask me again next year. I work for an organization where when you turn 50, your colonoscopy is free. Free, not even a deductible, just go and do it. I can't give them away. We have a very low rate of screening in the United States for colorectal cancer. Consequently, that's why we have so many different ways to screen people. So have y'all seen the new commercial for Get It, Got It, Gone? Or what is that little thing? Go, Get, Gone? I forgot what it was, but it's a very entertaining commercial. But the most entertaining thing about the commercial is this. What it is, you like poop in the box is the nickname of this test. Poop in the box. So you open up the little poop in the box, you put it under the toilet, you poop in the box. Close the box up. It goes in the mail. So there are two commercials. There's one of them. This is somebody's idea of a bad joke. You know who comes and picks up your poop in the box? The man who drives a brown truck. The little UPS man comes and gets your little poop in the box. So anyway, listen, I'm doing all of that to make you realize that there are a number of different ways that we screen for colorectal cancer, and you're going to have to find out what fits your patient. That's all I can tell you. Negotiate with them. Obviously, the gold standard is a colonoscopy, but we almost can't give them away nationally. I am changing gears. Let's talk about liver function tests. And when you say LFTs, most people think you mean an ALT and an AST. It's not what you mean. There's 6 tests generally that make up what most people know as liver function tests. And here they are. They all tell you something different about the patient. An ALT and AST is just a general measure of, hey, liver, how you doing today? You feeling okay with that Lipitor I have on board? If you want to know how well the liver is making things, its synthetic capacity, you look at the patient's PT and albumin. The liver is the only organ that makes albumin. If you want to know how well the liver is excreting things, you look at the patient's bilirubin. You look at their alkaline phos. You got it? So each of these parts of the liver function tests tell you a little bit about how the liver is functioning in a different way. So let me ask you these 2 questions. What might the following indicate? What does it tell you if you see elevations in ALT and AST? You know those are enzymes, right? They're enzymes that sit in hepatocytes, your liver cells. When liver cells die, they rupture and spill their contents. So when we see elevations in ALT and AST, it means that you have lost liver cells. If you lose too many of them, that's not good. We know that on a daily basis, every one of us loses liver cells. Just they get old, they senesce, and they die, and they spill their liver enzymes. So if I measure an ALT and AST in you, I'm going to find very low levels of ALT and AST. That's normal. But if you're killing, or a lot of hepatocytes are dying, those liver enzymes begin to rise. Consequently, that's a red flag when you find it. What might it indicate if you see an elevation in alkaline phos? Remember what that was? It demonstrated the what? Excretory capacity of the liver. We see rises in alkaline phos in 2 specific conditions. Bone problems and liver problems, right? So a rise in alkaline phos may tell you about a bone or a liver problem. So let you look at this patient. A pregnant patient is found to have elevated alkaline phos. Do you think that's pathological? The answer is no, I sure don't. We expect a pregnant patient to have an elevation in alkaline phos. How come? Because of bone and liver development in the fetus. We see that all the time. You don't even measure an alkaline phos in a pregnant patient because you know it's going to be elevated. Look at the next patient. What about an adolescent with an elevated alkaline phos? That's normal. Why? Because they've got bone and liver breakdown as they're beginning to grow. So there are 2 populations in whom we expect to see elevations in alkaline phos. Pregnant patients, adolescents. When you find it in other patients, we think of bone and or liver issues. Got it? So alkaline phos, you'll see that all the time. I think the two liver enzymes that will occupy the majority of your time are going to be ALT and AST elevations. And when we say elevations, we mean mild to moderate, up to 10 times the upper limits of normal. ULN means the upper limits of normal. 10 times the upper limits of normal is considered a moderate elevation. Why do people have that? Well, there are a number of different things we always investigate until we find the answer. But let me give you this little trick because I think it'll help you. When you see an elevated ALT and AST, you know that hepatocytes are dying and spilling their enzymes. When the ALT and AST are both elevated, but the ALT is the higher of the two, I want you to look at that L and say, liver. I know why their liver enzymes are elevated. They've got infectious hepatitis. If the patient's ALT and AST are both elevated, but the AST is the higher of the two, I want you to look at AST and say, oh, I know why the liver enzymes look like that. AST means acetaminophen, statins, and tequila. That's why their liver enzymes look like that. When the AST is elevated, it typically is something the patient has consumed. It might be a medication, and at this time of year, it often is. With cough and cold season, people take a number of those multi-drug things, and they get too much acetaminophen. So here's your take-home point. I want you to look at the ratio of the ALT to AST. When the AST to ALT ratio is greater than 2, we almost always associate that with alcoholic liver disease. That's just one of those givens. If the AST to ALT ratio is greater than 1 but less than 2, it could be alcohol, but it could be liver disease, so we don't really know. When the AST-ALT ratio is elevated but less than 1, you can put $10. No, make it 20. That it's fatty liver disease. All right? So the one you know for sure, greater than 2, is alcohol until proven otherwise. Less than 1 but elevated is fatty liver disease. So let's talk about fatty liver disease. What is that? Non-alcoholic fatty liver disease means that your liver has been infiltrated by fat. And it can't work so well. It is, look at this, it is the most common liver disease in Western countries. That means the United States. In the United States, you ready for this? It's the number one reason for liver transplants. It's not hepatitis C anymore. The number one reason for liver transplants in the United States is non-alcoholic fatty liver disease. So can it progress to cirrhosis? Yes. I'll tell you this. I was in I don't even remember where I was. I don't remember what city I was in. I was teaching this class. There was a lady on the front row. And I usually am talking to people on the front row. And she kind of had this yellowish look. So I asked her, how you doing? When are you going to take the exam? She said, well, I'm hoping to take the exam soon. I said, well, that's good. She said, because I'm on a liver transplant list and I'm hoping to get the exam done before I get a liver. I said, wow. I said, why do you need a new liver? She said, I have non-alcoholic fatty liver disease. She wasn't old. So what I'm telling you is, you will see this over and over again in your clinical practice. 10 years ago when we found it, we used to say, we see that in people with metabolic syndrome. Now we know it's a big old deal. So when we see elevations in ALT and AST less than 1, this has got to rise to the top of your differential diagnosis. It is a big, big deal.